A very good evening to all the viewers to this grand finale of Wikasepedia. Today we have with us Dr. Rujuta Mehta, who we all know is the Honorary Secretary of the Bombay Orthopedic Society. On behalf of her, the entire organizing committee and the Bombay Orthopedic Society Scientific Committee, I welcome you all to WIROC 2019. This conference is going to be held next week. I request all of you all to kindly register for this conference and attend this wonderful conference. Today, Dr. Rujuta Mehta is going to be speaking to us about infective non-unions, bridging the gap, and she's got a case as well as a good review of literature. So I now request Madam to kindly take over the proceedings and present her case and her presentation. Welcome, ma'am.
Thanks, Swapnil. First of all, let me congratulate Swapnil on the excellent series that he's been running so far. This is one of the very, very useful things which has been happening as the WIROC. And we really hope that the focus of this WIROC, which has been getting it right the first time in all sorts of situations which are practical and which are useful for the practicing orthopod as well as the postgraduate as well as the specialists, really serves its purpose. With this in mind, what I thought is something that a general orthopod really routinely encounters, and especially in our country, is something which is known as infective gap non-unions. And therefore, the case I have selected is pertaining to that. What I'm going to bring to you is something very simple, which can work in everybody's hands, provided we follow the technique and the principles to the T. So without wasting much time, let's go ahead. When we are faced with a situation like this, for example, a 6-year-old who came to us a little later than that which I put here, but I'm just taking you through the story of this poor child, an 8-year-old girl rather, who came to a general surgeon with fever, pain, and swelling of the left forearm of a few days in origin. Seeing that the arm was totally cellulitic and tense and the child was really toxic, the surgeon assumed, and since there was an area actually pointing here in the region of the radius, the surgeon actually assumed that this was just a simple abscess, and he went ahead with an IND, although the referring general practitioner had sent him this X-ray. Now, on first look, this X-ray was passed off as normal, but you and I as orthopedic surgeons can already see the dense tissue planes here. We can already see that this had a lot of marrow involvement and there was an impending path fracture as here. But like they say, the eye does not see what the mind does not know. This was completely missed. The forearm was drained as an abscess, and a few days later, she went to another surgeon with a discharging sinus with frank signs of radius osteomyelitis, was started on oral antibiotics because they were very hesitant to go in a young child. And hence, after some time when things did not respond, this is when we inherited the case in November 2014 with the presence of a frank discharging sinus, a lot of sequestration, and disappearance of the bone of practically the middle third of the radius with 2 pathological fractures. And you can see here in the lateral view that the entire middle segment was actually a sequestrum. This is what we did. We went ahead and did total counts, ESR and a CRP. We did a preoperative radiograph to evaluate the dimensions of the sequestrum and realized that we are going to be left with a huge gap once we debride this. And hence we thought it would be a good idea to bridge this with a spanning fixator, which is recommended in wet lesions till the infection subsides. And this is what was the final picture after the hysterectomy. You can see virtually the entire middle segment is off, proximal 2/3 of the radius remains. The distal radius was almost like a twig and just the metaphyseal portion. And we chose to use as less pin possible, one transfixing the radius ulna and one actually just only in the ulna there and one in the metacarpal here. And this was the lateral view. Here it almost looked as if majority of the radius is absent. We then went ahead as a second stage to reconstruct this. After debridement of the fibrous tissue and freshening of the bone edges, intraoperatively, we made sure that we sent tissue culture again a few weeks later. And this was what was left on table. This is the ulna, as you can see over there. And that's the refreshened edge of the radius. And that's the distal end. We then went ahead and harvested a mid-segment fibular graft from the leg under tunicae. Here you have to be careful leaving behind the distal fourth and going well below the common perolean nerve over here. And that was the kind of large segment that we harvested of the fibula under tunicae by the posterolateral approach. We protected the donor limb in an AK cast till the wound heals. This is what I will just recap of what we did on table. We refreshened the edges, took out all the fluid and granulation tissue at the non-union site, drilled both medullary canals of the radius with a long drill, harvested the fibula subperiosteally, and about 4 centimeters distal was left behind to prevent angle valgus. And we did a retrograde fixation with a long thick K-wire. Sometimes we use rush nails depending on the diameter that is available, and we retain the fixate at the same time. Sometimes we even use an AE cast depending on what the need of the patient is. And if it's the femur or the shoulder, we may sometimes use a hip spica. This is to show you how beautifully the entire harvested segment of the fibula has healed up after that. And that's the lateral view, again showing a good consolidation. This is how the graft looked on table. That's your original ulna. This is your harvested graft held together with a K-wire. That is how the X-ray looks. And the fixator pins were retained and the connecting rods were applied back on table. So the non-vascularized fibula bone was fixed at the site of the defect with the help of an intramedullary K-wire. Sometimes, case dependent, you could use plates or screws, but by and large, I think I prefer an X-fix. Or very occasionally, in some cases, there's a caveat, you may use cancerous bone grafting to facilitate non-union, to facilitate union and prevent the non-union. And that's our final reconstruction. That's what you can see, just a recap of the defect, the amount of fibula harvested and the harvest in place. That's the X-ray. And that's what our final fixation looked like. We made sure that the thin intramedullary K-wire stopped just short of the radial physis, and everything went on to really unite beautifully. So when you look at gap non-unions, we must first identify what all the problems are before deciding on a reconstruction. Large bone defects in pediatric age group are always challenging, and which is why, as you can see here in the tibia, for a number of reasons. The fragments become sclerotic and atrophic over a period of time. Sometimes, depending on which bone is affected, there is instability and shortening. The scarred soft tissue is usually adherent to the defect, as you can see over here in the form of a sinus. So separating out and getting good planes is difficult. And with subcutaneous bones, that tends to leave a large area exposed over there. You may end up with multiplanar deformities because it does not follow then the principles of good alignment. You will end up working with short segments with mismatched diameters. So you may not have enough options for fixation. And sometimes you have to resort to the hybrid kind of fixation, which I did in this case. Like you saw, the use of a nail as well as an X-fix. There are various options in other cases also if you want to make it hybrid. Not only that, not only the gap non-union, but there are proximal and distal joint issues, because the longer standing this problem is, either the joints get stiff or all the movement that you had was at the non-union site. And hence you are left with a lot of problems later on, that you may have a lovely looking X-ray, but not a mobile joint. So you need to be ready to address these problems as well. And with growth, because of the infection, you also have the proximal and distal tibia in this case is showing a growth arrest. So similarly, in other bones, you have residual problems left with to deal with. And hence, when you have such a lot of problems to kind of solve, what are your options? In some cases, you may resort to osteosynthesis with bone grafting, and you do acute docking and user plating, or an intramedullary fixation, depending on what your comfort zone is. But let me remind you, these have highly variable results in every bone. For example, in the femur, the plates works extremely well. But for the tibia or for the radius ulna, nails are much more preferred. If you're an expert in Ilizaro, you may use that with bone transport, or if you have access to a big center, you may even use a free vascularized bone graft, which is said to have the highest rate of union. Or in some cases where absolutely nothing else is possible, you may end up being nihilistic and converted to a one-bone forearm. But my choice, and I think universally, whether it be a nursing home, whether it be a teaching college, or whether it may be a corporate hospital, the workhorse or the non-vascularized fibula grafting works very well as compared to any of these options, because it gives you universally duplicatable results in every hand. So why did we not go in for the vascularized fibula in this case? Because it is technically difficult, needs special expertise. It may be an additional challenge if there is scarring and fibrosis of soft tissues, and therefore the vessels themselves may be thrombosed, the donor vessels on which this is based on. And despite all this, the graft may fracture because they are highly vascular, and this has been very well documented in the OCNA and Journal of Orthopedic Trauma. If you convert it to a one bone, that would be kind of your simplest option, but you use a lot of movement over there. You would have to fix this in mild pronation, which means a lot of day-to-day tasks which supination needed become difficult. The wrist and elbow ROM must be spared, otherwise you will end up with a completely stiff and non-usable arm. And the last, this should be really, technically speaking, the last resort for persistently painful and unstable forearm patients, as clearly outlined by Patterson and Jacobi in the hand surgery journals and in JPO. With other procedures, there are other issues as well, that free vascularized bone graft, although highest rate of unions, are not really feasible except at a tertiary referral center. These are 6 to 8 hour surgeries and may not always be give you the desired outcome. Plate fixation requires a lot of additional periosteum slipping. And for the IM fixation, the diameter mismatch cannot really be the best setting, because then you have a big problem of choosing a thin nail where you may be able to thread it through only the middle segment, but your metaphyseal ends still remain largely unoccupied, and hence that itself gives you instability. Sadly enough, maternal and paternal grafts are still being practiced in our country in a lot of children, because it is still believed that where there's difficulty in procuring bone grafts in children, and there seems to be no one-stop shop, really speaking. I'm personally not trained in Ilizaro, but yes, a lot of Ilizaro experts can really tackle these problems with Ilizaro. But again, there are limitations, like it cannot really be practiced at all ages. The very, very young children, you don't get frames really which can be fitted. It is, after all, a complex procedure, has a long training curve, and requires basically a viable length of proximal as well as distal fragments, so that you could have a secure hold to create a construct which at least holds 3 rings and even provide for further lengthening. So at the end of the day, when you're faced with a problem like the one I showed you, you need to know what works best in your hands. And to my mind, a non-vascularized fibula graft is something that will work in every hand, no matter where you practice. Is this something new that we're talking about? Not really. If you really look at literature, it was proposed way back in 1877 by Albert and P.C. Dell, where they used, compared it with conventional and cuff grafts, and they found that mechanically and biologically, these were the same at 6 months, and this fits more or less in the category of cuff grafts. In addition, it acts as a beautiful strut, and therefore there is structural strength. There is resistance to infection with infrequent donor site morbidity. It's a simpler procedure. It avoids the use of costly implants, and it is a more feasible and practical solution in all developing countries and small centers. And how is that? That is because it acts as a biological implant itself. Due to the refined nature, it tends to, even you could actually get an inherent stability by using it double barrel, or in places like the tibia or the femur, you could actually refreshen the edges in such a way that you can dock it by making it a triangular segment, and you can dock it inside the distal segment. And hence it forms a beautiful scaffolding. And what's more, if it unites really well, the more the child walks on it, it hypertrophies beautifully after consolidation. Don't believe me? Let me show you what I'm talking about. So coming back to our case, a year and a half later, as you can see over here, after the fixator was removed, the graft has beautifully consolidated with the parent bone. After refreshioning, we were left with such a small segment of the recipient radius, and yet this is how beautifully the whole fibula has got incorporated. A month later, we even removed the K-wire, and then subsequently went on to reconstruct the wrist in January 2015 because there was a loss of variance here. And instead of lengthening this, of course, there are other cases which I will show you now in which we have gone ahead and lengthened over the fibula, consolidated fibula graft as well. But here, since everything was pretty recent, we thought it's best not to disturb the consolidation, and hence we chose to shorten the ulna instead and transfix the radio-ulnar joint. This is her in 2016 with a beautiful consolidation and the medullary canal reappearing all over again, and the forecortex is also forming well. That's a function, and the child has gone on to do very well, except for a mild restriction of pronation over there. But this, a lot of it she accomplishes with rotating the shoulder, and the parents and the child both were truly happy with this result, and so were we. We've had a little bit of experience in doing this in various bone segments, and we ourselves have written this up way back in JBJS 2013. For those of you, these are the details if you want to refer to this paper, where we really advocate early aggressive debridement. Instead of a delayed sequestrectomy, we prefer to go in really early and use the use of span fixators. As you can see, different types of fixators shown in this picture. Mean time to union, what we find is between 12 to 16 weeks. So that means something like 3 to 4 months, really speaking, if you protect it well. And sometimes you need resurgeries depending on the case. But the time to union is directly proportional to the length of the gap that you have had to bridge. Some quick case examples of the same. As you can see, a femur over here with absolutely no metaphyseal segment here. This went on to unite well, as I'll show in subsequent slides. A lot of the tibiae, majority of them were femurs, some humerus. We've had gap unions of all type, the ulna and the radius, as you can see over here, majority long bones. That's again a hypertrophic type of non-union. We refreshened this. This was a completely flail forearm due to loss of the lever of the humerus here. And we could restore the length as well as the graft went on to consolidate very well. And this child had beautiful function and the lovely consolidation, as you could see over there. Some additional cases, as you can see, this was the tibia, which I showed you in one of the earlier pictures, reconstructed. Another femur. This femur case where I showed you, we used the double barrel fibula, and we actually did it twice using the fibulae from both legs, and eventually this went on to hypertrophy very well. Everything has not always been hunky-dory. 2 of our cases did refracture, and we had to use an external fixator, and in one case we had to even use the ELISA rod to further give compression. That was in an older child, and of course that was in the femur. So at the end of it, we thought that if you're using a femur, the implant or the hybrid fixation must always be supplemented with a plate and any other X-fix that you may use. For the humerus, again, where you have a large segment where your metaphysis and diaphysis is not going to match, again, we resort to plating. And those are our results, reasonably well done in most of them. So how do we achieve a desired outcome? You have to differentiate between smart work and hard work. And that, to my mind, is that do what is right for you and try to achieve only one thing at one time. So focus on union first and then talk about reconstructing or lengthening later. Yes, in many other cases, we have treated the subsequent problems as well. Like I told you, the problems are many, it's not just union. So after achieving union, we've had gone ahead and done 2 radial head dislocations, which required an open reduction. Another case of ulna where we used a lengthening procedure. And in the femur and in the tibia, as I will show you now in the next case, we have done 2 lengthenings as well. For example, this is the case that I was talking about, a 1.5-year-old child who came with a gap non-union of the right tibia post a soft tissue abscess, again, as usual. drained without keeping in mind the possibility of an osteomyelitis. Let me point out at this juncture that whenever you have a child coming with a short history of swelling and fever, and a lesion which is not respecting any tissue planes, or an infection which is deep to the deep fascia, even if there are no X-ray changes initially, it is an osteomyelitis unless proven otherwise. This child suffered actually a transient lateral popliteal nerve palsy when we were harvesting the fibula graft, but this nerve palsy recovered in subsequent time, and the fibula regenerated completely within 1 year. That was the fixation on table. Because of the very thin diameter, we used only a small rush rod out there. But despite that, this went on to unite beautifully. And this is the kind of hypertrophy that I was talking to you about, because he was only 1.5 when we started off. And by the end of 4 or 5 years, this is the lovely hypertrophy that he showed. We did one lengthening using an orthofix rail. If you go back to this picture, you can see how well the fibula has consolidated all over again. You could actually use it for a second time if you need be. That was him after a few years. We found that the fibula was overgrowing over there, and hence we did a screw epiphysiodesis here, and subsequently did Elizaro a second time, and yet a third time, after which now at the age of 11, this is what he is now, both limb lengths equalized, full function, lovely consolidation of both the grafts, and the ankle balance maintained well thanks to the epiphysiodesis of the fibula. So from there in 2009, that's where he has come in 2017 with full function. If you're dealing with a wet lesion, for example, in this femur, as has been very beautifully outlined in Journal of American Hand Surgery, the masculine technique for treatment of segmental bone loss in the upper extremity, but we've used it in the lower extremity here. So what we tend to do is we do a stage surgery in terms of first doing a sequestrectomy. And at that same stage, after a thorough debridement, we go ahead and put in a spacer with antibiotic impregnated cement. We usually prefer to use either vancomycin or gentamicin in the antibiotic spacer. I've already told you the concentrations of either using vancomycin or gentamicin. It's the same as what you would use for in your arthroplastic related cement spacers. Again, what is to be noted out here is that in this type of fixation, since there was very little hold on the distal fragment and the metaphysis itself was involved, we have chosen a single pin through the physis, but you have to take care not to violate the physeal plate there, and this has been used more as a spanning sort of a device till we could come in and do a more definitive fixation, that is using the locking plate there. We used a double barrel fibula tied together, as you can clearly see out there. Since this was a long gap, we needed a lot of diameter over here to be reconstructed, and there was hardly any distal hold. Those are the distal femoral locking plates which are freely available now. We also chose to supplement it with some amount of cancellous bone graft out there, and this is the healing after 6 months. You can see one of the grafts is totally docked into or interlocked into the proximal femur out there after triangularizing the shape, and this is going on to healing very, very well. So case dependent, you may use the fixation, but the fibula, given the right kind of supplementation, given the right kind of fixation, and on a clean, non-infected bed, can go on to do very, very well. So I would recommend the use of a non-vascularized fibula in most of your gap non-unions, because it's a useful and economical procedure. It's easy to reproduce at any center, does not really require a long learning curve as long as you have followed the principles of a thorough debridement and a good fixation well. If need be, you must not hesitate to use a supplemental hybrid fixation, but majority of these fixations are very easy to be achieved with your routine orthopedic training. There is no really demanding fixation device or a complex frame needed here, and it is very easy to manage post-operatively. So with this, I would say thank you very much. This is the right choice for me, and if you have any questions, I would be more than happy to address them during WIROC. So looking forward to seeing all of you over there at WIROC 2019 next week at the Renaissance. Thank you very much.
Thank you very much, ma'am, for sparing time for this wonderful webinar. And the message which seems to be coming across is there can be simple solutions to complex problems. For more such solutions to complex problems, I welcome you all once again to WIROC 2019. See you there. Thank you.
Thank you.